An 8-year-old child was brought to the emergency department with severe burns on his limbs and chest. The pediatric doctor has failed to insert a peripheral intravenous line due to significant burns. What is the next most appropriate method to deliver fluids for this patient? So if it's not possible to have a peripheral intravenous access, for example, a patient with burns or hypovolemic shock in which the veins are collapsed, then in these cases, the most appropriate method to deliver fluid in this kind of patient is intraosseous access. Intraosseous access is useful in major burns, septic shock, and cardiac arrest when it is difficult to place an intravenous line. Where the intravenous line is placed 2.5 centimeter below the tibial tuberosity at the proximal tibia. So this is tibial tuberosity, and 2.5 centimeter below this point, IV line is placed in the intraosseous vessels that are vessels that are non-collapsible and present in the bone marrow. So if it's difficult to get a peripheral IV access in case of shock and we need to replace the fluids, then the most appropriate method to deliver the fluid is intraosseous access. Now remember that all babies and young children in the
Is it
UK.
important to remember where this intraosseous access is, its location?
No, it's not important. It was just for your knowledge.
Right.
You just need to remember that if it's difficult to access peripheral IV line in case of shock or in case of burns or in case of cardiogenic cardiac arrest, then intraosseous access can be used to deliver fluids.
Okay.
So all the babies and young children in UK up to 4 years of age, they should receive 400 international units of vitamin D because of lack of sunlight. And the children who are less than 1 years, they should also receive vitamin D supplements at slightly lower doses, that is 340 international units per day. So up to 4 years, it is recommended that the children should receive vitamin D because of lack of sunlight. How we are going to manage a case of perforated hymen? In the Plab 1 exam, usually a female after horse riding develop red staining of underpants. In this case, we'll suspect a perforated hymen. And the next most appropriate action would be to examine the genitalia in a clinic without anesthesia and stop the examination if the child becomes uncomfortable or withdraws permission to continue. When you will consider general anesthesia. So if there is only suspicion of perforated hymen, then we can stop the examination if the child becomes uncomfortable or withdraws permission. If there is bleeding, active bleeding, or a foreign body is suspected or severe trauma is suspected, then examination is done under general anesthesia, even if the child refuses examination. So if medical attention is required, then we will do the examination under general anesthesia. Medical attention will be required if there is active bleeding or if there is foreign body suspected or severe trauma is suspected. Obstructive sleep apnea syndrome in children. Obstructive sleep apnea in children is similar to obstructive sleep apnea in adults. The diagnosis is also made similar. The only difference is that in the children, the cause is mostly due to enlarged tonsils or adenoids. So whenever you see obstructive sleep apnea in children, then you need to refer the child to an ENT surgeon, because the cause of obstructive sleep apnea in children is tonsils or adenoids. Remember that prolonged use of antibiotics can lead to a decreased immune system. And when immune system is decreased, fungal infections such as candidiasis can occur. For example, a breastfeeding mother has been treated with comoxiclave. So breastfeeding mother with a history of antibiotic use. Now she is having sore nipples that are pale with shiny skin. Her baby has white spot on his tongue. What should be done? So sore nipples with pale and shiny skin, and her baby also has a white spot on his tongue. This is most likely a fungal infection. So what should be done? We should give antifungal, local antifungal, such as miconazole gel for her mother's nipples and miconazole oral gel for the baby. Other side effects of comoxiclave, they include feeling of sickness such as nausea, especially when taking high doses. And if this occurs, then we need to take comoxiclave before food. Vomiting and diarrhea are also the side effects of comoxiclave. Next topic is osteomyelitis. Osteomyelitis is infection of the bones. Osteomyelitis or infection of the bones can occur by two methods. One is hematogenous osteomyelitis and the other is non-hematogenous osteomyelitis. Hematogenous osteomyelitis is that is seeding of the bacteria in the bones due to sepsis or bacteremia. Most common form of osteomyelitis in children is hematogenous osteomyelitis. And the most common bones that are affected in hematogenous osteomyelitis are vertebral bones. So vertebral osteomyelitis that is through hematogenous spread is common in children. It is usually monomicrobial and the causative organism is usually a single bacteria. Risk factor for osteomyelitis include sickle cell anemia, IV drug user, immunosuppression due to either medication or HIV, and infective endocarditis. Non-hematogenous osteomyelitis, it can occur due to trauma to the soft tissues or even bones. So someone with a history of trauma to the soft tissues or bones, if they develop signs of inflammation, such as redness, pain, and swelling, then it will be osteomyelitis due to or non-hematogenous osteomyelitis. Because of trauma, multiple bacteria can be present. So non-hematogenous osteomyelitis is often polymicrobial. Hematogenous osteomyelitis is common in children, while non-hematogenous osteomyelitis is common in adults. Risk factor for non-hematogenous osteomyelitis include diabetic foot ulcers, pressure sores, diabetes mellitus, peripheral arterial disease. While risk factor for hematogenous osteomyelitis include sickle cell anemia, IV drug user, suppression due to medication or HIV. Staphylococcus aureus is the most common cause overall, but in patient with sickle cell anemia, the cause of osteomyelitis is salmonella. So in generally, Staphylococcus aureus is the most common cause, while in patient with sickle cell anemia, salmonella is the cause of osteomyelitis. Investigation is MRI is the imaging modality of choice with sensitivity of 90 to 100%. And because Staphylococcus aureus is the most causative organism, most common causative organism, so the management of osteomyelitis is fluoxacillin or anti-staphylococcal penicillin. And if someone is allergic to penicillin, then clindamycin can also be given. For example, a 15-year-old boy had a penetrating wound a few days ago. Today, it has developed into an ulcer. He is limping and unable to bear weight, and there is severe pain. So, a boy with a history of penetrating wound, which developed into an ulcer, has now got limping and unable to bear weight, and there is severe pain. So, limping and inability to bear weight and severe pain and fever that is 39 degrees centigrade, heart rate, redness, and increased warmth over the plantar aspect of the first metatarsal bone. So all these are the signs of infection or the involvement of bone. So the diagnosis here is osteomyelitis. The most common causative organism is Staphylococcus, and the treatment is fluoxetine for 6 weeks, and if occupancy, then clindamycin. Tourette syndrome and Asperger syndrome we already did in psychiatry chapter. So I think there is no need to do them here. Now, when we will call a baby a newborn, from delivery up to 28 days of age, we call the baby newborn. After 1 month till 1 year, we'll call the baby infant. Between 1 to 3 years, we'll call the baby toddler, and 3 to 5, we'll call him preschool. Normal birth weight is usually between 2.5 to 4 kg. Low birth weight means less than 2.5 kg weight, and high birth weight mean more than 4 kg birth weight. The most likely outcome of a fully treated meningitis is complete recovery, while a delayed complication of bacterial meningitis is hearing loss. So if they ask about the outcome, your answer should be complete recovery. And if they ask about the most feared complication after meningitis, then hearing loss. Patent ductus arteriosus. Ductus arteriosus is basically the communication between pulmonary trunk and aorta. During embryological life, there is a communication between pulmonary trunk and aorta because the lungs are non-functioning. So that's why this ductus arteriosus is to transfer blood, oxygenated blood from pulmonary trunk to aorta so that it can be supplied into the body. After the birth, this duct is closed, but in some children, it may remain open, which is known as patent ductus arteriosus. It is common in preterm infants. Clinical features of patent ductus arteriosus, mostly it is asymptomatic. It can cause apnea, bradycardia, increased oxygen requirement, and bounding peripheral pulse. The most important point that you need to remember about patent ductus arteriosus is a continuous machinery murmur. So whenever you see this word that is continuous machinery murmur, your diagnosis should be patent ductus arteriosus. This murmur usually disappear with time and may even disappear by the time the baby is discharged from the pediatric ICU. The diagnosis is confirmed on echocardiography. It may close spontaneously or it can be closed by, remember that prostaglandins, they keep this ductus arteriosus open. So we can give prostaglandin inhibitors such as non-steroidal anti-inflammatory drugs, including indomethacin or ibuprofen. So patent ductus arteriosus may close spontaneously, or indomethacin or ibuprofen also be. So in a preterm baby, a continuous machinery murmur, your diagnosis will be PDA. The diagnosis will be confirmed on echocardiography, and the treatment is indomethacin or ibuprofen. Tetralogy of Fallot is also a congenital heart disease in which there are 4 features present, such as pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. Tetralogy of Fallot is one of the main causes of cyanotic congenital heart diseases. Now, congenital heart disease can be divided into 2 categories. One is cyanotic congenital heart diseases, and one is acyanotic congenital heart diseases. Cyanotic congenital heart diseases, they cause cyanosis because there is right to left shunt. Normally, the blood from the right side of the heart is pumped into the lungs. But if a shunt is present, this deoxygenated blood from right side of the heart is pumped directly into the left side of the heart. So because this is deoxygenated blood, and when this deoxygenated blood is pumped by left ventricle into the aorta, so it will cause cyanosis because it is deoxygenated blood. So what are the cyanotic congenital heart diseases? In cyanotic congenital heart disease, there is right to left shunt. There are 5 conditions. One is truncus arteriosus. So ductus arteriosus is different from truncus arteriosus. Truncus arteriosus is when there is only one outflow tract. Normally, there are 2 outflow tracts. One is pulmonary trunk and one is aorta. But in case of truncus arteriosus, a single vessel is present. Second condition that is cyanotic congenital heart disease is transposition of great vessels. Transposition of great vessel is that pulmonary trunk arises from aorta and pulmonary trunk arises from left ventricle and aorta arises from right ventricle. Tricuspid atresia, tetralogy of Fallot, and total anomalous pulmonary vascular return. These are the 5 conditions which cause cyanosis in children.
What happens in transportation of great vessels?
Transposition of great vessels mean the position of the great vessels is changed.
Right.
Left pulmonary trunk originate from left ventricle.
Right.
And aorta originates from right ventricle. So aorta will receive deoxygenated blood.
Right.
So that's why it will cause cyanosis.
Okay.
Because aorta is originating from right ventricle, so it will receive deoxygenated blood. This condition, truncus arteriosus, transposition of great vessels, and tricuspid atresia, they are usually not compatible with life.
Right.
So the baby usually die in the womb of the mother. Only tetralogy of Fallot is compatible with life. So that's why. And tetralogy of Fallot is more common than all these conditions.
Right. And these are all congenital.
Yes, these are all congenital or genetic diseases mostly.
Right.
There is developmental defect in the heart.
Right.
And these are all cyanotic conditions. And in these are all have a right to left shunt. Now, acyanotic congenital heart diseases. Whenever there is a left to right shunt, there will be no cyanosis. Because when the blood is shunted from left heart to the right heart will send it to the pulmonary circulation, and then it will return to the left heart again. So in left to right heart, oxygenation of the blood is not affected. That's why they are acyanotic conditions. For example, atrial septal defect, ventricular septal defect, patent ductus arteriosus, and coarctation of aorta. All these conditions are acyanotic congenital heart diseases. They have a left to right shunt. Because normally on the left side of the heart, the pressure is high. So in case of atrial septal defect, ventricular septal defect, patent ductus arteriosus, the blood is shunted from left to right side due to high pressure on the left side circulation. So that's why there is no cyanosis in these conditions. This is a diagram which is showing patent ductus arteriosus. You can see this is pulmonary trunk and this is aorta. This communication, this small vessel that is known as ductus arteriosus, because in fetal life, the lungs are not functioning. So the blood from pulmonary vasculature is pumped directly into the aorta, and then it is supplied to the body. Sometime in the exam, a question is asked about the innocent murmur. Remember that innocent murmur is asymptomatic, low intensity, soft blowing, systolic murmur that is heard on left sternal edge. It is heard in children mostly between 3 to 8 years of age, and it is due to turbulent blood flow at the outflow tract of the heart. It is more evident in the presence of fever and spine position. It is a benign physiologic murmur, so there is nothing to worry about. So if in the exam, in the question, you see a description of the murmur as a soft murmur of shorter duration, sweet, systolic, single, and sensitive, and heard in supine position or during the fever, then your answer should be innocent murmur. Now, next topic is APGAR score. APGAR score is usually calculated immediately after the baby is born, 1 minute and 5 minutes after the birth. It can be repeated if after 10 minutes if the score is low. A score of 0, 1, or 2 is given on the basis of appearance, pulse, grimace, activity, and respiration. If appearance is blue, 0 score. If appearance is the extremities are blue, but the body is pink, then we'll give 1 score. And if the all the body is pink, then we'll give 2 score. Similarly, we can and activity. For example, if the baby is floppy, then 0 score. Some limb flexion, then 1 score, and all limb flexion, then 2 score. So this is how we can calculate APGAR score. And if the score is 3, then it is a very low score. If the score is between 4 to 6, moderate low, means the baby is in a good state. Age of 5, who may be at risk. If a child has a fever and at least one of the following symptoms, these symptoms are red light symptoms, then we can say that these children are at a high risk of complication. So these are red light symptoms such as blue or pale color, grunting, respiratory rate more than 60, moderate chest in drying, reduced skin turgor, non-blanching rash, bulging fontanelle, focal neurological signs, seizures, etc. So a question may present with several features ranging from green to red traffic signs, and then ask you which one is the most concerning. So that's why it's important to remember these concerning signs and symptoms in children. Umbilical granuloma. Umbilical granuloma is moist red lump of tissues that can form on a baby's navel. So a red and moist tissues that can form on baby's belly button. It can be seen in the first few weeks of life after the umbilical cord has dried and fallen off. It usually an inner problem that it looks worse than it is. And umbilical does not cause pain. So you will only need to reassure the patient that it will resolve in its own. But if there are signs of infections, how it can be managed? If no signs of infection, then table salt is the first line and silver nitrate is the second line. And if signs of infection, then we need to give antibiotic. For example, if pus is present, then fusidic acid, topical fusidic acid will also be prescribed. Now some points about vaccination schedule. Contraindication to vaccination, they include history of anaphylactic reaction to vaccine or a component of vaccine. These are general contraindications. That is anaphylactic reaction to vaccine or any component of the vaccine. Similarly, live vaccines are contraindicated in immunocompromised patients and pregnancy. Similarly, if the baby is having fever, high-grade fever, though high-grade fever is not a contraindication for vaccination, but if a baby is having fever, then we can delay the vaccination until the baby gets better. Now remember that vaccination and egg allergy, what is the association between vaccination and egg allergy? There are two vaccines in the UK that contain small amount of egg protein. One is MMR vaccine and one is flu vaccine. Remember that the egg protein that is present in MMR vaccine, it does not trigger an allergic reaction. So if someone is allergic to egg, he can receive MMR vaccine. While the egg protein that is present in flu vaccine, it can trigger an allergic reaction. So if someone is allergic to egg, then he cannot receive the flu vaccine that contain egg protein. In these cases, we will give egg-free inactivated flu vaccine. Two vaccines should not be given to the patient with HIV. HIV is positive patient, no matter whatever the CD4 count is. We cannot give BCG or TB vaccine or yellow fever vaccine to patient with HIV positive. And if CD4 count is less than 200 ml, less than 200 cell per ml, then we will avoid MMR vaccine as well. We already know that pregnant women in the UK should receive influenza and DPT vaccine between 20 to 32 weeks of gestation. Now some genetic diseases. The first one is Wilson disease. It is an autosomal recessive disease in which there is copper deposition in the liver due to deficiency of ceruloplasmin, that is a ceruloplasmin is a copper binding protein, plasma protein. So when there is a deficiency of ceruloplasmin, what happens? Copper is deposited in the tissues such as liver and CNS. So these are the two important organs where copper is deposited, that is liver and CNS. So someone with liver problem and with CNS problem, such as hepatosplenomegaly, deranged LFT, and cirrhosis, plus ataxia, dysarthria, dystonia. If these two systems are involved, liver and CNS, then your diagnosis will be Wilson disease. Initially, LFTs and serum ceruloplasmin to confirm the diagnosis. That is serum ceruloplasmin levels are very low, less than 0.1, and the treatment is lifelong penicillamine. Penicillamine is basically a chelating agent that binds with copper and excrete it from the body. And if the child develops acute liver failure, then liver transplant is the option.
So where is this ceruloplasmin it's coming from? Sorry,
Ceruloplasmin is a plasma protein. It is present in the plasma.
So
Is
can you
that what
please
you are
explain
asking?
that? Yeah. So can you please explain again because I didn't follow that.
Ceruloplasmin basically binds to copper.
Okay.
So when there is no ceruloplasmin in the plasma, what will happen? Copper will be free.
Right. Also, then it gets deposited.
Yes, so it will get deposited in the tissues, and
Okay.
most commonly in the liver and in the brain, in the CNS. So
Right.
that's why if you see a child with the involvement of these two symptoms systems, that is liver and CNS, liver problems, they include hepatosplenomegaly, cirrhosis, and range LFTs, and CNS problems include ataxia, dysarthria, dystonia. So if these two systems are involved, plus there are behavioral changes such as decreased school performance and personality changes, again, it indicates the involvement of CNS. So you will suspect Wilson disease, and you will confirm your diagnosis by doing serum ceruloplasmin level that will be very low or less than 0.1. Lifelong penicillamine is the treatment, and if liver failure, then liver transplant. Similarly, another disease that is hereditary hemochromatosis. Hereditary hemochromatosis is iron accumulation due to increased intestinal absorption of iron. Iron accumulate or is deposited in the tissues. The tissues in which iron is deposited, it includes pancreas, which will result in diabetes mellitus, liver, which can result in hepatomegaly cirrhosis, just like copper, and skin, hyperpigmentation of skin. In joints, deposition of iron will result in arthropathy, and in heart, arrhythmia and cardiomyopathy and SOB. So remember that in hemochromatosis, in Wilson disease, there was involvement of two systems, CNS and liver. In hemochromatosis, liver, pancreas, and skin. That is a triad of hepatomegaly, diabetes mellitus, and bronze skin or hyperpigmentation of the skin. Remember that if this triad is present, then your diagnosis will be hereditary hemochromatosis. Remember that liver is the most likely organ to get cancer in hemochromatosis due to cirrhosis and iron deposition. So involvement of liver with CNS, Wilson disease, involvement of liver with pancreas and skin, hemochromatosis, involvement of liver with lungs, alpha-1 antitrypsin deficiency, then some other condition in which involvement of lung with kidneys, that is Goodpasture syndrome, and involvement of lungs with kidneys plus hearing loss and loss of vision, Alport syndrome. We have already discussed these conditions. Now, Ehlers-Danlos syndrome, Marfan syndrome, and Prader-Willi syndrome, and Duchenne muscular dystrophy, and trisomies 13, 18, and 21. All these we have discussed in genetics diseases chapter, so there is no need to discuss them again. Cystic fibrosis was also discussed there. Newborn screening test in the form of heel prick test is also discussed in genetic disease chapter. In this diagram, postural drainage technique is shown that is done in case of cystic fibrosis. So our pediatrics chapter is also finished.